Hello, my name is Tim Buie, and I'm a pediatric gastroenterologist working at the Lurie Center for Autism, which is a program at the Massachusetts General Hospital for Children. It's a program that takes care of children with autism from a multidisciplinary medical care program point of view. Today, I'd like to talk to you about the microbiome and how it may affect children with autism. This is really a relatively general talk, and it will touch on issues about the microbiome that I think will apply to other medical conditions, but we'll focus primarily on the impacts on autism as far as we can judge. I've listed for you on this slide a list of objectives that I'd like to cover in this time frame. I'd like to disclose that I've done work for other companies, and I've done speaking for Autism Speaks. I've done speaking for Nutritional, which is a nutritional formula company, Crestovo, which is a company that does fecal transplant work. I've also had funding from a number of other programs for research work that I do. I don't intend to talk about specific products today that should be germane to anything that would be a conflict of interest for me. I want to show you a face of a child with autism, and this is certainly a child who is really quite extreme. This is Billy, and he is quite self-injurious and aggressive at times, but mostly he has self-injury, and he has times where he will be quite agitated, he can't get settled, and he'll simply hit himself in the face repeatedly. We originally felt that those issues were discomfort for Billy. We didn't think this was a behavior of his autism. We felt that this was something that was wrong with him physically. And originally, when we took care of him, we tried treating him for acid reflux, which is a common reason why we see these behaviors. Interestingly, he responded nicely for that for some time, but then he developed new behaviors. And on this next video, you'll actually see Billy eating a meal. And as he eats this muffin, he is working through trying to swallow the muffin down. And he has some of the behaviors that we think are very telling for gastrointestinal distress. He has posturing. He draws his arm up. He is grabbing at his chest. And he clearly looks like he's having trouble bringing that food down. At times he gets so agitated that he has to stand up in the middle of a meal almost to help clear that esophagus as things are moving down. And what we realized was that that was a different condition. Billy had developed a condition called eosinophilic esophagitis or allergic esophagitis. This is a condition that causes swelling in the esophagus, and it may be food-related or swallowed environmental allergens, but it's a very interesting issue that includes abnormalities in the microbiome of the intestine. And so we realize that patients who have these medical conditions have disruptions of their microbiome. We've worked on Billy and his symptoms by treating acid reflux, but we've also done a number of dietary adjustments that have been really helpful for him to reduce the issues with swallowing. And these are behaviors that have remarkably diminished as we've focused on those physical things that were going on to set those problems off. The prevalence of autism, as most of us know, has been on the rise. When I was in medical school and graduated from medical school in 1984, the prevalence of autism was 1 in 5,000 individuals. You can see since 2000, these numbers have been noted to be rising, and so the current prevalence of autism is about 1 in 68 individuals, according to the CDC. This is reported every 2 years' time, and so we're about to see new data that'll speak to what's happening currently. But it's been on the rise over this time frame, and no one's had a really good explanation for why it's been on the rise. We know that autism is heterogeneous, and so children with autism present in a host of different ways. Many of them are nonverbal, some of them have some language, many of them have comorbid medical conditions. We know that it's common for them to have associated genes. We don't know how to sort out all of the gene issues for them right now, and many kids have very characteristic genes that can cause autism or autism features, but many have not been identified. And as we've gone through the way that we do genetic testing at this point, there are many kids with abnormal genes that we don't have an explanation for what they do currently. We know that there's associated psychopathology pathology. And so what we thought was obsessive compulsive behavior as part of autism now may be an independent entity of OCD or hyperactivity, attention deficit. All of those conditions are commonly seen in kids with autism. We also know that issues that are medical, such as epilepsy or gastrointestinal issues, are pretty common in this group of patients, and they may happen at different times. We're starting also to recognize that conditions like food allergy or other immune dysregulation has been seen in this population, and catatonia, which is a condition that's been described as a psychiatric disorder, seems to develop in some patients in the late teens and early 20s in a number of these patients. We don't have an explanation for why that happens. We know that in terms of gastrointestinal issues, that the frequency of GI problems seems to be a good deal higher than the general pediatric population. And we did a consensus study looking at the literature back in 2010 that was published in the journal Pediatrics that talked about the kinds of presentations that these children have, including acid reflux, including constipation, etc. A more recent paper by Barb McElhennon at Emory has reported that there's about a 3.2 times higher frequency of these gastrointestinal issues than the general pediatric patient population. So according to these studies, somewhere between about 50 and 70% of kids with autism will have chronic gastrointestinal symptoms as well. These findings are many, and so different studies have reported the presence of inflammation in the gut. People have reported symptoms consistent with acid reflux. Increased intestinal permeability or leaky gut has been described in a number of studies. The finding of leaky gut in particular has been somewhat inconsistent, and partly we recognize why these studies may be variable is that the testing for intestinal permeability is really quite poor, and doctors who do this work haven't been able to show a well-done standard of what accounts for increased intestinal permeability. We do a number of studies where we give a non-absorbable sugar and we measure for that sugar in the urine to see if that sugar has leaked across the gut lining, for instance, but it hasn't been reliable even from the same individual at different times to really help us know how many of these kids have this increased permeability. But permeability is important because if the permeability of the gut is disrupted, it's probably how we sensitize to food proteins and develop food allergy. And so if there's a problem with digestion or there's a problem with inflammation, there may be increased permeability as a result of that, and that may be why we're seeing a higher frequency of food allergy or other issues in this population. And we know from work that's done at the Mind Institute, among other places, that there are altered immune responses in the gut of children with autism. We became involved in the research component of autism when we were asked to look at a particular issue, which is the suggestion that vaccine injury might be accounting for autism in the late 90s. This was work that suggested that measles virus vaccination might actually be causing a low-grade measles infection in the gut lining, and that this was somehow contributing to intestinal permeability that might be causing neurological features. When we were able to replicate that study, we couldn't find the presence of measles virus in the gut, and maybe more importantly, we were able to find features of autism before these children ever received the MMR vaccine. So we were really able to show that that hypothesis, that idea of at least that vaccine insult, really wasn't accounting for autism in the patient population that we were studying. And as a result, because we're a busy clinical group, we've also been able to do a number of other translational studies looking at other issues. In the group of patients that were captured by CAN, looking at a genetic database, we were able to look at that database and find that there was a higher frequency of a MET gene abnormality, which is an oncogene, but it's associated with GI conditions in our autism population. And these MET gene abnormalities may be present in those kids where there is a worsening of GI issues, although that has not been a uniform gene abnormality in kids with autism. We've also done other work, and I mentioned a paper in 2010, which was a consensus paper, where we tried to not only look at the literature and decide what was going on in the GI community, but also try to give guidelines to pediatricians about how they should work up children with autism around the medical issues that are going on. And our primary statement was that children with autism have a right to a medical workup, that they have problems that really merit an investigation, and that it's important to really consider these underlying medical conditions that may be making those children with autism worse. And although it may not be making the autism worse, it may be making the behavior of those children worse or their focus worse so that they could not make progress. We made suggestions in that paper to suggest that these children really need a dietitian to evaluate them and make sure that they don't have evidence of dietary insufficiency that might be accounting for some of these problems. And so we made a number of recommendations, and also as a result of that, we had a recommendation paper that was a sister paper to this that made suggestions to the pediatric gastroenterologist how to do a workup on these children. The discussion about microbiome has been everywhere, and so it's almost impossible to go to a newsstand these days without seeing some journal that's talking about the intestinal microbiome and its relationship to some disease. And I think we're going to focus in on that, but let's talk about microbiome in particular. And the microbiome is the makeup of a bacterial environment in a certain setting. So we don't have one microbiome, we have microbiomes. There's a different makeup of the bacterial environment in the respiratory system than is in the upper GI system, than is in the lower GI system. And these microbiomes are present everywhere, in the skin, in the sinuses, everywhere in the body. And we depend on these bacteria to produce byproducts that are also nutritive and important to us. And so the presence of these bugs really is an interplay with our own bodies. And we know that there's more than a microbiome. We know that there's more than bacteria that make up these environments as well. We know that there are fungi that are present throughout all of these environments. We know that there are viruses present throughout the environments, and that the interplay with bacteria are activating these viruses at various times throughout the life of an individual, and that the bacteria is really having an impact on the immune environment of these individuals. We know that there are byproducts of all of these bacteria and fungi that create a metabolome. The chemical byproducts of these bugs then produce enzymes and chemistry that communicate with the nervous system and are directly affecting what the brain is perceiving about each of those organ systems. This is an example of the bacterial makeup in the human microbiome. And you can see that when you look at the intestine, there's a very high diversity factor of the number of bacteria in the lower intestine in particular. We've been able to identify that in a given individual, somewhere between 500 and 1,000 different species of bacteria make up that environment. And the species that make up my lower intestinal environment are different than the species that make up yours or the individual sitting next to you. And we know still that we've only been able to speciate these organisms in the last 3 or 4 years. So we're probably missing a number of these bacteria and other species. We know in the upper GI tract, because of the acidity of that environment, that there are very few bacteria that actually can reside in that upper GI tract, and so that it's much more typical to find only about 25 species up in that upper GI tract that are acid tolerant. We know in the respiratory tract there are higher numbers of bugs, and they are the bugs that often get activated to cause diseases in that area. So this is a growing interest. How do these bugs get activated to cause disease? How can we suppress them to prevent disease? This is where a lot of the current research is going. And we realize that as we identify these things, we still don't know the job of each of these bacteria, and this is what we're trying to learn through current research. We also know that those bacteria develop in different stages. And so a girl who becomes a woman has changes in her microenvironment before she's about to give birth to another child. And she has had changes from her mother's environment because of antibiotic exposures or life exposures or dietary changes or travel changes that may affect those bugs. And as she develops into a woman and then becomes pregnant, things that happen, including hormonal changes, may change that microbiome. Things that we expose mother to, including her vaccinations, et cetera, may change that microenvironment. And so a number of things may impact the new baby who's born to that mother. And the way that that baby is born is certainly important. We know that a child who's delivered via C-section gets a very different way of getting colonized by mother's bacteria than if she passes through the vaginal canal in the process of birth. So it's extremely important to recognize that things that we do right at the time of birth affect how the bacterial flora establish themselves in that infant. We know that exposure to antibiotics, which is very, very common during the last part of pregnancy for various reasons, and at immediate birth. If child issues occur, such as fever in the newborn unit, we're exposing those children immediately to antibiotics. That may change that microenvironment, and the compatibility between the baby's environment and mother's environment may be impacted by that. The development of the microbiota is probably happening before birth. We used to report that the meconium, that first passage of stool from a baby, was sterile. We now know that even that first stool that's passed by a baby has the presence of bacteria, and so that baby's acquired exposure to bacteria before coming through the birth canal, through probably disruptions in the placenta or disruptions in the amniotic fluid during the last months of the mother's trimester, most likely. But so that impact on the immune system is probably happening even before the baby is born because of the bacterial makeup that's present. And then delivery mode we've already talked about. How we feed a baby has a significant impact on these infants. And we know that there is a remarkable diversity improvement, more bugs developing in the microenvironment in a baby who's fed via breast milk than fed formula. And so it's made us look back to advocate for breastfeeding in that first few months in particular, because that probably has bearing on the infant's diversity of the bacteria. We know that medications and antibiotics are an issue, and we know that other things happen during those first few years of life that may change how these bugs colonize the system. This is a slide that talks about the difference between the diversity of children born via C-section versus vaginal delivery. And you can see at the bottom of the slide VD versus CS. And those children who are delivered via C-section, most of them have a remarkable reduction in the diversity of the bugs, the number of bugs that make up their microenvironment in that infant period of time. So that vaginal passage is extremely important to expose to a number of these bacteria initially. We know that the microbiota diversity increases over time, and so gradually there is an increased number of bugs that start to make up the intestinal environment, and that by about 36 months, by about 3 years of age, most children have developed the final diversity that they're going to have for the rest of their lives. The diversity that they've got at 3 years of age is pretty much parallel to what they'll have as adults. And that's gradually increasing, although certain things may be impairing the increase in that diversity over time. And we know what matters is that if you don't have that diversity, you have a higher frequency of a number of medical conditions. We know that if you've got low intestinal diversity in the first month of life, that there's a higher frequency that you will develop asthma over the course of the next several months of life. So that low diversity is not protective, higher diversity is protective of certain diseases. We think that that's exactly the same graph that we would see for the prevalence of food allergy. So if patients who have low diversity in those first month or 3 months will be much more likely to have food allergy and develop some of these allergic phenomena, eczema, et cetera. We know that by 100 days, another study shows that there's a higher frequency of asthma And so this is starting to bear out in terms of replication studies, where we're actually able to support that this idea really holds up and is not so much a hypothesis anymore. There's really better and better support that this is a true issue for these individuals. We know that studies that have looked at the microbiome in infants from birth monthly over time have shown that if children have an antibiotic exposure, they have a remarkable reduction in their diversity over the course of the next several months. And so that early antibiotic exposure, because of an ear infection or other early illness, really impedes development of a normal, broad-based, healthy bacterial environment. And that's been borne out not by this study, but many studies at this point in time. So the idea that this diversity is happening has really now expanded to the fact that low diversity is probably impacting a number of conditions, and that it may make us more prone to diabetes. We may be more prone to obesity as a result of low diversity. Cancers may be more common in patients who've got diminished diversity of their microbiome. Inflammatory bowel diseases such as Crohn's disease may be much more common in individuals who have lower diversity. And even what we've called functional disorders like irritable bowel syndrome or colic, it seems that if you've got diminished diversity, you're at a greater risk for those types of conditions that we've considered to be motor problems of the GI tract and not really related to this environment. One of the difficulties of this work is that it's really been only within the last 2 or 3 years that we've been able to look at these bacteria down to the level of the species. We've talked about families of organisms for quite some time, and ratios of firmicutes and Bacteroidetes, which are common families of bugs, have been abnormal in certain environments. But only now can we look at individual organisms and try to look at the function of those organisms in the community to see what's going on. And even at this point, the research centers that are funding these work are not interested in what the bacteria are anymore. They're seeing the studies that show what bacteria are present. They're interested in what the bacteria does or what the metabolic byproducts are of those bacteria as they look to fund this research work. Here's an example of irritable bowel syndrome showing that it's really got a unique bacterial component or a unique diversity compared to control patients. And so in the old days, we talked, meaning 2 years ago, 5 years ago, 15 years ago, we talked about irritable bowel syndrome as being a functional disorder, that these people are more sensitive to stretch in their gut, or they've got impaired motor clearance. And yet we can see a distinct difference in the bacterial environment that might be accounting for a lot of those changes. It's hard to know whether the bacteria become disrupted because of the motor issues in the GI tract, or whether the bacteria are causing the motor issues in this gut at this point. And that's why it's very difficult for us to sort through what is chicken or egg. But I think it's extremely important to at least recognize these differences. And now I look at in irritable bowel patients, or patients that I would have characterized as having relatively functional type disorders, as being a unique entity, that bacterial environment's different, and I need to work with that environment to take care of those patients. One of the ways that we've learned best about the differences in how the microbiome develops are twin studies. And so this is an example of a twin study that suggests that patients who are born as twins, so we assume relatively similar birth mode, and we assume exposure to vaginal colonization, et cetera, to be pretty similar in those twins, that over time, a twin who develops disease, ulcerative colitis, has lower diversity of their bacterial environment than their twin. So something happens over those years that causes them to be at greater risk in that environment. And we know that in that population, they had particular bacteria that were diminished. So lactose fermenters, which were able to break down carbohydrate sources, were significantly diminished in the patient population of ulcerative colitis compared to the control twins who did not have disease. And so it may be that we're going to learn that these bacterial functions are really important about how we digest and how we handle food products coming through. Another study looking at twin studies was an obesity study that showed, again, if you had higher diversity on that higher line of the graph, you were much less likely to have obesity than the lesser diverse twin. that twin who had lesser diversity was much more likely to be obese in this study. And so it's extremely important, as I see it, to try to find ways to foster that diversity as we can as older individuals as a way of treating disease. And this is the pathway that people are looking at for all sorts of conditions at this point. We know that decreased diversity is associated with inflammatory bowel disease. In this slide, it's actually in the red line in the middle compared to the controls above you. In the lowest population, the obese population has significantly less diversity even than those patients with inflammatory bowel disease. And so this is a confirmation of those other studies showing that that lack of diversity is really notable related to the control population. What about autism? This is what we're doing work on, and there certainly seem to be now a number of studies that have suggested that there's a change in the bacterial environment in children with autism. These early studies were really looking for whether there might be pathogens. And so as we summed up the studies that were available, I published that in a paper in Current Clinical Therapeutics that talks about the studies in this population. And one of the studies that we participated in with our own patient population identified a particular pathogen called Sutterella. And Sutterella is known to associate with colitis and maybe causing colitis in some individuals. And so it was a finding that we felt might support why children with autism might have intestinal inflammation or irritation. Other groups that have looked at the microbiome in autism have not been able to support that finding of Sutterella, but other groups have found high clostridial counts to suggest that if you have an increased quantity of particular bacteria of the Clostridial family, that those patients may have more likelihood issues of autism than their control population. We all think about Clostridia species such as Clostridium difficile, which is known to cause a severe inflammatory colitis after antibiotics. But most Clostridia have a positive function. They come into the bowel flora after there's been an intestinal insult. And yet, if there's a high quantity of Clostridia in our patients with autism, maybe this is a marker for the fact that that intestine has been insulted in these patients. Or maybe children with autism can't handle the metabolic byproducts of Clostridia, and that might be promoting autism features or behaviors in those patients. This is the work that needs to move on from the finding of high Clostridial species or diminished Bacteroidetes species or other things that have been listed out there in the research work. We've recently had a paper submitted and accepted for publication looking at the upper intestinal microbiome, and we found that there were diminished Bacteroidetes in that area, which is consistent with a number of other studies, and this will be published within the next 6 months in the Journal of Pediatric Gastroenterology and Nutrition. One interesting thing about the gut microbiome is that diet definitely makes a difference, and we talk about that, but this is a graphic to suggest those differences. And so you can see that a vegan who is taking in primarily vegetable-based product and fruits, it has a really broad-based microbiome, that if we add meat to that and we become omnivorous, that there are still diverse bugs, and so it's not diminishing the bugs to a level that we're at great risk, but it also varies significantly how much of our dietary intake is based on meat or other types of products. And so we can definitely see that we can alter the makeup of that flora by doing changes to our diet that might be helpful for us in terms of our treating ourselves for our medical conditions. Here's an example of some differences in the microbiome makeup with particular dietary changes. And so this is a graphic that looks at control patients who've got normal BMI, a group of patients with high BMI, and then a group of elite athletes who are taking in a diet that's extremely high in protein. And you can draw a line between the high protein intake athletic patients and even patients who have normal BMI on the other side. And this is simply, I think, suggesting that we may benefit or make some very nice positive changes in that microbiome if we increase our protein intake significantly in these individuals. And certainly one of the differences in these elite athletes is that they may be doing something else by their physical activity and by their general health that fosters that microbiome makeup. And this is something that we need to learn as well. How much does exercise or physical activity or fat burning as part of our physical effort, have an impact on the microbiome. That really hasn't been well characterized at this point in time. So this is a slide that suggests that there may be different modes of communication from the bacterial environment to the brain. These bacteria may be producing metabolic byproducts that directly affect the vagus nerve, and that there's a nerve feedback up to the level of the brain. These metabolic byproducts also may communicate directly to nerves in the gut lumen that communicate directly to the brain, or communicate through these metabolic byproducts through the circulatory system up to the brain. So there are a number of ways that something happening very locally in the gut may be telling the brain information that changes what the brain does. Well, is there a way to fix any of these things? We've talked about diseases and the lower diversity in these patients. So I want to talk about the possibility that we could make changes. And the die probably is cast for a general makeup environment by age 2 or 3, that there's a setting point for your bacterial environment, but we may be able to make impact if we have an impact on antibiotic exposure, if we have an impact on the diet. And this it really points out to me as a pediatrician that I need to be very focused under age 3 on impacting the microenvironment in a healthy way, but I also need to think about what I do once my environment is set. There are a lot of people who feel like they know how to fix this, and I think there are a number of diet books out there talking about this topic. There are a number of people that are talking about ways that you can give supplementation in the diet that may favor the microenvironment. We'll talk about a lot of those potential treatments as we go. I want to talk about a couple things in particular: prebiotics and probiotics. We talk about these terms. We've looked at the term prebiotic as in the past, a support for the microenvironment. And at this point, we've sort of parsed that, and prebiotics are now nutrient supports for the bacterial environment. And so these are usually oligosaccharides, or short-chain sugars, that are not digested by the organism or poorly digested by the organism to provide nutrition to the bacterial environment rather than to the person. And these are products including in breast milk, human milk oligosaccharide, or fructose oligosaccharide, among others. Probiotics are healthy bacteria, or they're intended to be bacteria that serve particular purposes. They may improve digestion through enzymatic activities to help break down carbohydrates, or they may have an impact on the microenvironment itself to balance the environment, and they may, by their presence, improve diversity. There's another term I'd like to use, which is xenobiotics, and these are the chemicals or preservatives that are present in foods. And these products we have very little information about, but we know that the presence of these products in the diet are probably impacting the microenvironment, because we know certain food supplements may be impacting obesity, et cetera, and we're going to touch on that in a moment. How about what we've learned about the importance of these products going back to the very first food that we see, and that's breast milk? We can see that the major component of breast milk is water, but as we move across, we find that one of the major nutrient products in breast milk is human milk oligosaccharides. And this is a product that we can't replicate commercially yet, but it's the nutrient that really feeds the bacterial environment and the acidophilus and bifidophilus and lactobacillus species that are so common in infants in those first few months of life. And so we now know that it's extremely important to give that nutrient support, especially over the course of the first 3 to 6 months of life, if it's at all possible, because we cannot replicate this product in infant formulas, although we've tried to make up and give some reasonable differences to that. These human milk oligosaccharides have these bifidogenic properties, and you're going to see the term bifidogenic in terms of what people are looking at for prebiotics, et cetera. These favor healthful, acid digesting, carbohydrate digesting probiotics in the gut, and they are very favorable for improving digestion and health as far as we know. The benefits of prebiotics have really been well supported now. And so if we can be giving some nutrient support to the bacterial environment, there's pretty good data that we can show increased diversity in infants now based on a number of randomized controlled trial studies. And yet, even though we may improve digestion, we don't see that that accounts for increased weight gain or other types of issues. It seems to do some things that are favorable for the bowels, including lower the stool pH, which is usually helpful for constipation. It may prevent against harmful bacteria. It may prevent actually against intestinal infections, including viruses, to have that environment established in those first few months of life. One thing that is lacking in our diet now compared to other places culturally in the world, such as Africa, is fiber. And I was never an advocate of supplementing fiber for issues like constipation, because the pediatric studies looking at supplementary fiber for constipation really suggest that there isn't much benefit in improving constipation. And in fact, I found that clinically, if you gave fiber in kids who were constipated at the time you started it, you often saw increased gas or bloating or distension in those individuals, and they still weren't more able to go. We now know that fiber is a primary source for this bacterial environment in the large intestine, and it's probably the most common source for nutrient support to foster a more diverse bacterial environment. So I'm now really strongly advocating fiber in the diet, especially of children, and if we can keep that going through lifetime. We also know that there are differences in fiber, so it seems like it's important to have fiber that's from fruit and vegetable sources maybe greater than grain-based fibers, at least in terms of promoting health and limiting disease. The fiber sources from the food that we're eating may be much, much more important in particular. We know, for instance, that if we can give prebiotics and fiber to an individual with obesity, we've changed the environment in those patients metabolically that may promote weight loss. And so this is really one of the settings where supplementary fiber and supplementary prebiotics have been quite successful in individuals. We know probiotics have a number of mechanisms, and so here's an example on this cartoon that looks at the impact on competitive exclusion, meaning that these are healthful bugs that may take up residence along the surface lining of the gut and force out bugs that are sort of less favorable. We also know that there is this impact on intestinal permeability, and that certain prebiotics, or rather certain probiotics, have an impact on permeability. This is work that's been done at a number of places, including Sarcus Masmanian at Caltech, showing that Bacteroidetes in particular seems to improve intestinal permeability, and that's why it may be helpful in individuals with inflammatory bowel disease and other conditions. We know that these probiotics probably modify the messages that get sent to the brain through signal transduction and immune regulation. We know that timing of probiotics is important in terms of medical conditions. And so if we have a research project where we're inducing colitis in a mouse, we can prevent the development of that colitis by giving probiotics sooner. And if we give probiotics before the onset of colitis, we may actually shorten the illness or blunt the severity of the illness. And so this is a suggestion that really the idea that we should be using probiotics as a preventative is really quite valuable. And it may be that we're going to find that the person who's established probiotics in their daily dietary program may be much more likely to get through an illness or a viral insult and handle that illness better. We know that there are particular strains of bugs that have been studied for particular conditions. And so this is a slide that looks at using a particular probiotic for colic, and that it was effective in reducing colic features. Other studies have been using that same product to treat recurrent abdominal pain in pediatric patients. But if you look at the studies that have been done for particular probiotics, they've been done for particular reasons. And so here's a slide that looks at a number of different probiotics for a number of different conditions. And how those studies have been done by sponsorship. The company that makes this product will do a research project looking at a particular condition. So it's possible that these probiotics may have other broad-based effects beyond treating these particular conditions. We know that some of those particular conditions haven't been studied. And so I can't give you a particular best probiotic for a particular condition yet. I think that's work that's currently being done. We know that most probiotics don't set up residence. And so this is a slide that actually shows one particular probiotic being given that is able to establish residence in a particular population. And so when these patients were given this probiotic, about 30% of the patients were shown to have persistence of that probiotic after the probiotic stopped being given. But for the most part, I think we should think about probiotics as a support, and that they will need to be given chronically if they're going to be given as a therapeutic value for a particular treatment. I think that the idea of these bacteria setting up residence is going to be really important. And are there ways that these bacteria can become part of the host microbiome is work that people are really actively looking at this time. How about brain-gut connections? Are there others that we could speak about? There are a few things I'd like to talk about, and this is a slide where we know that if we do things to disrupt the microenvironment, we can create an antisocial mice. And so mouse research shows that we can disrupt the flora with antibiotics, and that dysbiosis that occurs as a result of antibiotic exposure actually can cause a mouse to become somewhat less social and interactive. And that if you replace that patient's or that mouse's bacterial environment with a probiotic, you can actually replace the socialization of that mouse. So we know that changes in that environment have an impact on socialization. We also know that they increase neurotransmitters, and so there's clear data to say that supplementation with probiotics may increase the production of neurotransmitters in the gut of mice, including things that seem to have anti-inflammatory properties, etc. So there is great value in sort of stimulating a more healthful environment with probiotics. This is a study that I think is quite compelling in the autism research work, and this is Elaine Sal's work, who's at Caltech at the time, where she induced an inflammatory state in a birth mother of mice, and the mice in that setting developed autism features. It's hard to characterize what is autism in a mouse, but these mice were antisocial. They wouldn't socialize with their litter mates. They weren't afraid. They would walk across the cage without being worried of predators. So they lost certain features that would be quite characteristic of their normal character. They also developed repetitive behaviors. They would constantly bury their food pellets in a way that looked to be obsessive compulsive, as we see in our individuals with autism. And what they showed, which is quite interesting, was that when they gave a probiotic, particularly Bacteroides fragilis, they were able to correct these socialization defects, and the mice became much more normal or less autistic in their behaviors. This is completely impressive and hasn't been replicated at this time, but certainly has compelled that group to try to look at ways to go forward with the clinical trial of giving this as a therapy for individuals with autism, and that's something that we look forward to. We know that there are a number of other studies now that show that there is an altered microbiome in this setting, and that those microbiome changes seem to at least relate to rumination and abnormal thinking and abnormal cognition in these individuals. And so clearly when the environment is disrupted, this has an impact on the way that we think. It probably also has a way of impacting how we feel or perceive pain or emotions. And this is a study that was done by Emran Mayer's group at UCLA that showed that giving a fermented milk using the probiotic features that are present in common yogurt, that they could show changes in the brain activity of healthy women. And these areas of the brain that were studied in this group of individuals were primarily pain sensitivity regions and emotional sensitivity regions. And so the patients who were given fermented milk had improvements in those areas. And there were these real activation changes in the brain, despite the fact that this was milk that was given in the level of the gut. And this is, I think, a model that then might translate to conditions such as irritable bowel syndrome, where we know that there's increased pain sensitivity, and we know that there may be a visceral response and emotional lability as a result of these changes physically. So let's get to the fixing part. If can we fix this? I can't quite finish that statement with yes, we can, but I'd like to say yes, I'd like to try. And if I were to try to talk about ways that I might change the environment, I certainly want to talk about how we can change things from the very beginning. We know that these changes in the microbiome have had a significant impact on how we think about cesarean section delivery, and it's driven us in the last 10 to 15 years to move back away from C-section delivery unless absolutely necessary in a patient because of infant risk. So many years ago, women would schedule their C-section 8 months later when they found out they were pregnant for convenience or for ease. That's not the thing to do in this setting, because we know now that we're having such an impact on the infant. If we deliver these children via C-section, we need to try to fix that. We need to be very cautious about antibiotic exposure during mom's pregnancy, maybe even before mom's pregnancy, so that it doesn't impact mom's flora. And we certainly need to be very sensitive to antibiotic exposures in those infants, especially in the first few months. Certainly there are occasions where we cannot choose not to give antibiotics. There's times for safety that we need to make that choice. But the child who comes into the pediatrician who may have an ear infection might be the child that we would choose to watch carefully and not put on an antibiotic if it's at all possible. We need to focus families back on breastfeeding, and it's extremely important to go beyond that getting in colostrum. Many working moms try to get in colostrum in the first 2 to 3 weeks, thinking that that's a way to improve the immune state. But we know now that it's part of the nutrient support that we need to give these infants for the period of up to several months. And these kids really show this benefit of diversity if we can encourage mom to breastfeed for a minimum of 3 months' time. And I would strongly advocate that moms, even for a portion of the feeds, continue to breastfeed for at least that duration of time. We need to get fiber back in the diet, and certainly fiber as food is the best way to get fiber into the diet in these individuals rather than trying supplementation. But if we can't get it in through standard dietary intake, and many of my individual kids that I take care of with autism are so rigid and restricted in the foods that they eat, I find that I have to get some of these products in through supplementation. We've seen some progress, and we know that the national rate of C-section right now is still almost a third of babies born via C-section nationally. The guidelines that have been suggested by organizations, the World Health Organization in particular, is that we should be setting a goal of reducing C-section nationally to somewhere around 23%. So we are at least trending in the right direction, and we're bringing the number down at this point. So we're really working toward changing these issues. We know that C-section delivery in Hawaii, for instance, is at about 27.2%. So that's a pretty good number compared to the national average, but currently in Hawaii, the rate is on the rise. So we need to be cautious and really turn this state around and get them to recognizing that they really should be reducing that rate if they can. We need to look at the breast milk C-section delivery and antibiotic exposures in that first 2 years especially, and we need to look at modifications of the diet that might help. So dietary modifications that I think would be helpful in some format, may not to be fad-based or any dramatic changes other than considering reduction of overall carbohydrates in the diet. I think we should really moderate how much carbohydrate is in our diet. In the setting of remarkable obesity, we've recognized that by reducing overall carbohydrates, we can really impact the obesity factor. That's where we build fat. We also need to make sure that we're maximizing protein intake. We don't need to take high protein diets, but we need to make sure that we're meeting our protein needs as best we can. And we're not so sure what to do with fat at this point in time. At least we don't want to be on super high fat diets, but we don't find fat to be a particular culprit as far as we can tell in terms of disrupting the microbiome. We want to get in fiber as a fruit-based source. We want to look at whether yogurt or fermented type foods could be implemented into the diet as our source of probiotics. And so most of our delivery could be completely through food-based sources if it's at all possible. We certainly need to be nutrient conscious. And so if there are limitations in our diet where we might be vitamin D deficient or iron deficient. All of these are cofactors that are necessary to building a healthy microbiome. And so it's important to look at a diet and make sure that we're meeting those needs, especially individuals who are on restrictive diets. If they are for some reason on a milk-free diet or other limited diets such as a milk-free and gluten-free diet, etc., we really need to look at the nutrient makeup of the diets that those people have replaced, and make sure that we're meeting these needs. It's very, very hard to make up calcium, for instance, if we limit the milk dramatically from an individual. And so we need to find out how we're going to make up those deficiencies that might be present. And those unique restrictions, people who have chosen to be on very restricted diets of particular sources, we don't know if that's going to make a positive impact on the microbiome yet. We know that non-caloric sweeteners don't do good. They seem to cause problems, and they certainly cause a higher increase a greater increase in obesity in individuals. When we think we're trying to reduce carbohydrates, so many people have moved to these diet products, and they've actually seen a worsening in obesity as a result of that. That's that xenobiotic effect of those chemicals. They are doing something else to the microbiome, probably to promote firmicutes or these bugs that are food scavengers and that actually hold on to calories. But that needs to be better characterized as time goes on. Emulsifiers, dietary additives, etc., probably are doing the same thing. So one of the things that we really should advocate whenever possible is to give non-prepared foods, to really give straight whole food type products as a healthy way to deal with these potential cofactors in the diet that might be promoting problems. And this is another slide that talks about the impact of the nutrient supports such as iron or vitamins on the microbiome as well as the immune system. These things are necessary to build a healthy balance of all of these issues. Supplements as best we can through food, but we will find that we need to find some supports through supplements. And I think we need to look at the supplements and make sure that even in the supplements that there are not added dietary factors that might be setting off problems. For instance, many prebiotics or probiotics are made with milk-based products. And so if those individuals have to be on a milk-free diet, we need to look at the added ingredients to some of these products to make sure we're not adding an additional factor to the problems. I'd like to thank people who've invited me to be here in Hawaii, including the Hawaii Autism Foundation, who brought me here to give this talk. Originally, Julianne and Don King were the founders of that foundation, and a number of other people helped to bring that group together. Shannon Pucci was our coordinator that brought us here. We were able to do work here at the Shriners Hospital for Children, which is the only program in the country in the Shriners organization that is providing autism care. And they're building out a medical program, so they've included gastroenterology, and they have nutritional supports within their autism center here, which is really an exceptional model, very similar to some of the multidisciplinary programs elsewhere in the country. Ryan Lee is the neurologist that runs that program. Jeremy King is the gastroenterologist here in Honolulu who sees those patients. These are the people that I collaborate with at Mass General, and I've had help with these slides from Phil Sherman, who's at Toronto Sick Kids, and I've had other supports. Newman's Foundation has been extremely supportive of me over the years, including Autism Speaks, and the Autism Research Foundation have helped to fund the work that I've done. Thank you.